Cardiac Disease and Pregnancy, Part 1. Introduction. Cardiac disease remains the leading cause of maternal death in UK. Cardiomyopathies and ischemic heart disease are each responsible for about 25% of total deaths, with sudden arrhythmic death and aortic dissection making up another 25%. Valvular disease accounts for a little under 10% of cardiac deaths. Pregnancy and labor presents a significant cardiac stress to women. As a generality, women who are symptomatic with minimal activity before pregnancy, particularly if symptomatic at rest, are likely to have a stormy course of pregnancy with mortality in the order of 20 to 30%. Pre-pregnancy counseling is crucial in high-risk individuals. This table helps differentiating common signs and symptoms of normal pregnancy from those that are abnormal and indicative of underlying heart disease, based on history of cardiovascular disease, self-reported symptoms, vital signs, and findings of physical examination. The following findings prompt evaluation by pregnancy heart team: history of cardiovascular disease, self-reported symptoms, shortness of breath at rest, PND or autopnea, bilateral chest infiltrates on chest X-ray or refractory pneumonia, chest pain at rest with minimal exertion, palpitations associated with near syncope, exertional or unprovoked syncope, heart rate 120 or more, systolic BP 160 mmHg or more, respiratory rate 25 or more, oxygen saturation less than 95 under room air, JVP visible more than 2 cm above clavicle, loud systolic murmur, diastolic murmur S4, lungs, wheezing, crackles and effusion, marked edema. The mWHO risk class for the cardio-obstetric patient, Class 1, Class 2, Class 3, and Class 4, has been discussed in SAQ 77, mitral stenosis in pregnancy. Planning for delivery framework. Outline includes who, what, when, where, and how. Regarding who, assess the patient's condition and risk, and identify the pregnancy heart team. Regarding what, decide on vaginal or cesarean delivery. Regarding when, determine the time of delivery, either term, early term, or preterm. Regarding where, determine the type of medical center, maternal levels of care required for the patient. Some patients may need to be delivered in SOAP centers of excellence. Regarding how, determine the anesthetic and medication plan, access and monitoring, postpartum hemorrhage management and recovery. Regarding who, the cardio-obstetric patient should undergo an individualized assessment and have an individualized antepartum, labor and delivery, and postpartum care plan developed by an expert multidisciplinary pregnancy heart team. These should include preconception counseling, risk stratification and education, multidisciplinary coordination, and careful planning guided by a multidisciplinary team. Pregnancy is not recommended in women of Class 4 mWHO risk class due to extremely high risk of mortality and morbidity. For example, in patients with pulmonary artery hypertension, severe ventricular dysfunction EF less than 30%, NYHA class 3 to 4, previous peripartum cardiomyopathy with residual impairment, severe MS or AS, systemic RV with moderate or severely reduced function, severe aortic dilation or severe coarctation, vascular Ehlers-Danlos syndrome, and Fontan with any complication. Have a written plan for the delivery and ask the woman to keep a copy on her at all times. Members of the pregnancy heart team. Core pregnancy heart team consists of cardiologists, obstetrician, maternal fetal medicine specialists, anesthesiologists, nurse specialists, and additional experts to consider when creating a pregnancy heart team includes obstetric anesthesiologist, cardiothoracic anesthesiologist, cardiothoracic or ECMO surgeon, other CVS specialists such as in heart failure, adult congenital, pulmonary hypertension, electrophysiologists, imaging specialists, interventionalists, other experts, intensivists, geneticists, neonatologists, hematologists, pharmacists, pulmonologists, and perfusionists. Reasons to consult cardiothoracic anesthesiologists includes lesion triggers such as severe right or left-sided heart failure, systemic right ventricle, with moderate or severely decreased ventricular function, Fontan with complications, symptomatic heart failure, severe MS, severe AS, pulmonary hypertension, any unstable cardio-obstetric patient, presence of major CVS support device. Anticipated monitor or procedure triggers includes titration of inotropes, need for echocardiography in management, need for pulmonary pressure monitoring, maternal decompensation requiring GA, cardiothoracic surgeon or ECMO standby, and need for combined cardiac procedure and delivery. Obstetric trigger includes heart failure and preeclampsia. Regarding mode of delivery, medical counseling focus on the risk of morbidity and mortality, highlighting maternal CVS risk, fetal risk, and obstetric risk. Counseling should include management and mitigation strategies. Individualized care plans developed by the pregnancy heart team should consider the patient's anatomy and physiology, access to healthcare, delivery facility capabilities, and availability of multidisciplinary expertise. Shared decision-making is essential, especially in those with the highest risk of morbidity and mortality. Decision to continue a very high-risk pregnancy is personal to each patient and should be respected. Modes of delivery options includes vaginal or cesarean delivery. Vaginal delivery, for patients who carry a pregnancy to near term or term, vaginal delivery is the preferred mode of delivery for most patients due to the reduced risk of obstetric complications and allows more gradual hemodynamic changes at the time of delivery, which is favorable for women with high-risk cardiovascular disease. Compared with cesarean section, vaginal deliveries are associated with reduced blood loss, reduced wound infections, and reduced VTE events. Valsalva maneuver during vaginal delivery. Maternal risk includes reduced preload during Valsalva may not be tolerated by patients with left-sided obstructive lesions, such as severe MS, AS, or HOCM. Aortic shear stress that results from large stroke volume ejected from previously empty and now full ventricle presents risk to patients with underlying significant aortopathy. Valsalva maneuver is reasonable for most other patients with cardiovascular disease. Assistance in the second stage to avoid prolonged or forceful Valsalva may be considered in select patients with the highest risk of decompensation, such as in those with ventricular dysfunction or failure, Fontan circulation, and severe pulmonary hypertension. Caesarean delivery is reserved for obstetric indications, patients who are at very high risk of decompensation at the time of delivery. Caesarean delivery is also reserved for coordination of care in select cases, such as when concurrent caesarean delivery and CVS procedures are planned, for example, peripartum valvuloplasty or mechanical circulatory support. Timing of delivery. This is highly individualized on the basis of complexity and severity of cardiovascular lesion, presence of signs of clinical decompensation, NYHA functional class, associated comorbidities, anticoagulation status, and need for interventions that could be safely performed only in the postpartum period in the non-pregnant state. To preserve optimal newborn outcomes, the goal is to achieve 39 weeks gestation, unless there is concern for maternal or fetal decompensation. Location of delivery. For mWHO Class 2, these patients can be co-treated by maternal fetal medicine specialist and a cardiology consultant and may be delivered at a local hospital. For patients who are mWHO Class 3 or more, they should be delivered in maternal level 4 care centers, which are tertiary care centers with the ability to provide cardiac surgery, specialized critical care cardiology, and involvement of appropriate cardiac subspecialist experts, such as in pulmonary hypertension, adult congenital heart disease, and aortopathy specialists. Various services provided in maternal level 4 care centers includes continuous drug infusions to control arrhythmia, mechanical circulatory support, administration of inhaled or IV pulmonary vasodilators for severe pulmonary hypertension, and support of cardiothoracic surgeon or ECMO. Conduct of anesthesia. Hemodynamic changes peripartum and plans for mitigation. Important changes include increased catecholamines, reduced SVR, increased cardiac output, increased pulmonary blood flow, and reduced oncotic pressure. Increased catecholamines are attributable to pain and anxiety and leads to tachycardia and arrhythmias. Plan: avoid sudden alterations in heart rate and rhythm with neuraxial anesthesia for pain control. Reduced SVR is attributable to neuraxial anesthesia, pregnancy hormones, and hemorrhage. This leads to reduced coronary perfusion from decreased aortic diastolic pressure and increased LV and diastolic pressure. Plan: control sudden reduction in afterload and SVR with appropriate use of vasopressors. Increased cardiac output occurs through labor and delivery to accommodate the expected autotransfusion, and this may precipitate heart failure. Support the myocardium with inotropic medications or veno-arterial ECMO, diuresis as necessary. Increased pulmonary blood flow may lead to increased pulmonary pressures if pulmonary vascular resistance cannot decrease. Plan: provide pulmonary vasodilators, control sudden changes in blood volume with diuresis, avoid triggers that increase PVR. Reduced oncotic pressure may lead to pulmonary edema, provide diuresis as needed. The anesthesiologist should work with the pregnancy heart team to create a care plan specific for the cardiovascular anatomy and physiology in the context of anesthesia care for labor and delivery or cesarean delivery. This peripartum care plan should be created early when possible, usually in pregnancy weeks 20 to 28, and made available in the patient's medical record that is readily accessible to all members of the pregnancy heart team to view. There is little evidence to suggest that one anesthetic technique is superior to another. Therefore, a clinician's comfort and expertise in specific practices and modalities cannot be overstated. No two cardiac disease states look the same in a pregnant woman. The heterogeneity contained within should underscore the importance of an individualized approach that relies on assessment of each patient's underlying cardiovascular disease and hemodynamic status. Anticoagulation. Pregnancy is a prothrombotic state. Thrombotic events contribute to major morbidity and mortality, especially in pregnant patients with cardiovascular disease. Patients with mechanical heart valves are at high risk in pregnancy. Anesthetic assessment of a parturian with mechanical heart valve. History. Assess etiology of valve dysfunction, type, location, number and size of mechanical heart valve, presence of any concurrent cardiac conditions, history of previous embolic events, arrhythmias, and experience with previous anesthetic interventions. Ascertain the presence, severity, and progression of any cardiac symptoms during pregnancy. Evaluate the presence of other medical and obstetric conditions. Review medications, and document medication allergies. Examine the airway and spine, signs of heart failure, absence of valve clicks and appearance of new murmur could suggest valve thrombosis or obstruction. Evaluate biomarkers such as troponins and BNP, ECG, echocardiography, and review other available imaging. Echocardiography can provide information regarding valve area, valve mobility, valve thrombus and pannus, prostatic valve regurgitation, and gradient across the mechanical heart valve. Warfarin, despite its known teratogenicity, is the anticoagulant of choice for women with mechanical heart valves if the daily dose is less than 5 mg per day. This table summarizes the international recommendations for management of anticoagulation in parturients with mechanical heart valves, detailed by the European Society of Cardiology in 2018 and American College of Cardiology, American Heart Association in 2020. This algorithm details the anticoagulation management of patients with mechanical heart valves during pregnancy. In women with a mechanical heart valve planning for pregnancy, counseling before conception is recommended. When pregnancy is confirmed, provide multidisciplinary care in a specialized center, maintain therapeutic anticoagulation, INR 2 to 3 for mechanical aortic valve, and 2.5 to 3.5 for mechanical mitral valve. If warfarin dose required is 5 mg or less per day, during first trimester, options include continue warfarin, or low molecular weight heparin or IV unfractionated heparin. Second trimester, continue warfarin with or without aspirin. Third trimester, continue warfarin with or without aspirin. When warfarin dose is more than 5 mg per day, during first trimester, options includes low molecular weight heparin or IV UFH or continue warfarin. During second and third trimester, options includes low molecular weight heparin or continue warfarin with or without aspirin. Planned delivery, discontinue warfarin at 36 weeks or 1 week before delivery and transition to low molecular weight heparin or continuous IV unfractionated heparin. For IV unfractionated heparin, discontinue IV unfractionated heparin 4 to 6 hours before delivery. If the patient is on low molecular weight heparin, transition to IV unfractionated heparin 36 hours before induction or delivery. Discontinue therapeutic low molecular weight heparin for 24 hours before induction or delivery. If patient is on warfarin, cesarean delivery after reversal of anticoagulation. After delivery, commence anticoagulation with IV unfractionated heparin 4 to 6 hours post-delivery or low molecular weight heparin as per AOA or ASRA guidelines. Switch to warfarin in 7 days. Anticoagulation can affect the timing and safety of neuraxial anesthesia. Therefore, the pregnancy heart team should be involved in decisions on peripartum anticoagulation. To avoid spinal epidural hematoma, neuraxial techniques should be timed according to anticoagulation, medication, and dose. This table is a summary of the ASRA and pain medicine guidelines and the Society for Obstetric Anesthesia and Perinatology consensus statement with regards to timing of neuraxial anesthesia in patients on anticoagulants. Anticoagulation strategy should also include a plan for events that may lead to early or unplanned delivery. Anesthesia for vaginal delivery. A vaginal delivery with effective neuraxial analgesia is the preferred mode of delivery for most patients with cardiovascular disease. Options include epidural analgesia, CSE or CSA. Neuraxial blockade reduces plasma adrenaline and noradrenaline during labor, hence early central neuraxial blockade is beneficial. Epidural catheter also facilitates anesthesia for cesarean section if required. Avoid using loss of resistance test using air during epidural to reduce the risk of air embolism and paradoxical embolism via intracardiac shunts. Slow titration of central neuraxial blockade local anesthesia to avoid hemodynamic decompensation. Maintain afterload at baseline to ensure coronary perfusion, especially in patients with left ventricular hypertrophy, left ventricular outflow tract obstruction, stenotic valve lesions, pulmonary hypertension, and intracardiac shunts. Consider IABP monitoring in these patients. Consider avoiding the need for pre-CNB fluid bolus in patients at risk of pulmonary edema. Hypotension should be treated with vasopressors and small volume crystalloid boluses or inotropes. Anesthesia for cesarean delivery. Neuraxial anesthesia is typically preferred for cesarean delivery, including for patients with mWHO class 3 or 4 lesions. The choice of anesthetic technique should be individualized to the patient. Patients with mWHO class 1 or 2 cardiac disease typically tolerate a traditional intrathecal dose of LA for cesarean delivery. Depending on the CVS lesion, patients with mWHO class 3 or 4 may benefit from a more gradual onset sympathectomy. Options include epidural technique, CSE technique with intrathecal opioids and epidural local anesthetic, or sequential CSE technique in which intrathecal opioids and low-dose bupivacaine are administered 2.5 to 5 mg, followed by a slow epidural medication titration of local anesthetic, typically 2% lidocaine, to a T4 to T6 surgical level. Sequential CSE technique provides greater block reliability and symmetry, with better block consistency of intrathecal LA and more gradual onset sympathectomy of epidural LA. Minimize crystalloid fluid co-load in patients at risk of pulmonary edema. Initiate titration of prophylactic vasopressor to maintain SPR and blood pressure at maternal baseline, as to maintain coronary perfusion, regardless of neuraxial technique used to achieve adequate anesthesia. Options include phenylephrine infusion and noradrenaline infusion, titrate to maintain heart rate more than 60 beats per minute, and MAP near baseline. Regarding general anesthesia, indications include cardiopulmonary decompensation necessitating intubation. For example, post-delivery uterine involution plus aortocaval decompression, leading to autotransfusion and decompensation. In a patient with cardiovascular disease who is dyspneic, hypoxemic, and cannot lie supine before caesarean delivery, then GA with intubation may be indicated to prepare for potential cardiopulmonary decompensation immediately after delivery. GA is also indicated when neuraxial anesthesia is contraindicated, such as in current anticoagulation, severe thrombocytopenia, and maternal refusal. Monitoring during anesthesia: provide standard ASA monitors, intra-arterial blood pressure monitoring for mWHO class 3 or 4. It helps assist titration of vasopressors. Provide special focus of IABP during induction, second and third stage of labor, caesarean delivery, and postpartum hemorrhage. Pulse oximetry and continuous ECG monitoring for all patients with cardiovascular disease. Focused cardiac ultrasound reduces the time to diagnosis and treatment of conditions, helps assess volume status and guide fluid administration or diuresis, helps assess left and right ventricular global function, regional wall abnormalities, pericardial effusions, valvular status, and changes in proximal ascending aorta. Transesophageal echocardiography may be required in patients if transthoracic imaging is not adequate. Central venous and pulmonary artery pressure monitoring for patients with cardiopulmonary decompensation, right ventricular failure requiring titration of vasopressors and pulmonary vasodilators, and in those who are subject to large volume shifts. Complications of pulmonary artery catheters includes arrhythmias, bleeding, VTE, etc. It is generally deferred unless there is a need for cardiopulmonary bypass, continuous pulmonary pressure or cardiac output monitoring in patients with moderate or severe pulmonary hypertension, and in patients with severely reduced ventricular function in the intensive care unit postpartum. Bedside transthoracic echo can be used for cardiac function and output assessment when considering less invasive alternatives. ECMO. The standard ECMO circuit includes drainage cannula, venous access, blood pump, flow meter, pre-membrane pressure monitor, pre-membrane blood gas analyzer, oxygenator, post-membrane blood gas analyzer, post-membrane pressure monitor, and return cannula. For veno-venous ECMO, drainage cannula is via femoral vein, return cannula is via SVC. For peripheral veno-arterial ECMO, drainage cannula is via femoral vein and return cannula via femoral artery. ECMO is an important last-line support for acute respiratory failure, ventricular failure, or cardiovascular decompensation. Veno-venous ECMO may be necessary to treat refractory hypoxia, especially in cases of respi failure attributable to infections or shunting. Veno-arterial ECMO effectively offloads the right ventricle and is ideal for supporting patients with acutely worsened pulmonary hypertension or patients with severely reduced ventricular function refractory to medical management. If the use of ECMO is anticipated, perfusionists and surgeons should be notified so that they can be available. Insertion of a small placeholder sheath, 5 French in femoral vein and artery, before any procedures can facilitate rapid cannulation for ECMO. Reported cases of successful resuscitation with ECMO after peripartum cardiac arrest indicates that deployment of an ECMO team, if available, early in a maternal cardiac arrest can be life-saving. Postpartum hemorrhage. Patients with heart disease are at increased risk of postpartum hemorrhage. Hemorrhagic shock in the setting of CVS disease may initiate rapid hemodynamic deterioration. Regarding uterotonics, oxytocin should be titrated with an infusion pump. Avoid bolus dosing to avoid rapid reduced SVR. Regarding carbopros or hemabate, side effects include increased PVR, PAP, bronchospasm, abnormal VQ, increased intrapulmonary shunt, hypoxemia and death. Consider avoiding in patients with pulmonary hypertension. Ergot alkaloids such as methyl ergonovin or ergometrin are potent vasoconstrictors. Avoid in certain cardiovascular diseases such as pulmonary hypertension. Tranexamic acid may be considered in early treatment of postpartum hemorrhage after delivery when initial medical therapy fails. Avoid in patients with known contraindication to antifibrinolytic therapy, such as thromboembolic disease during pregnancy. The Women Trial, an international randomized double-blind placebo-controlled trial of 20,060 women with BPH, showed reduction in death attributable to bleeding in women treated with tranexamic acid and demonstrated no significant increase in thromboembolic events compared with placebo. There are case reports in non-obstetric patients of coronary stent thrombosis with tranexamic acid use. Tranexamic acid should be used with caution in the presence of coronary stents. Obstetric maneuvers such as uterine massage, prompt surgical management, uterine compression sutures, and Bakri balloon placement should be considered early in addition to maternal uterotonics. Timely blood transfusion, when indicated, is essential. Point-of-care cardiac ultrasound may be helpful in assessing volume status. Early evaluation for and use of veno-arterial ECMO may be life-saving in cases of massive hemorrhage in patients with severe or decompensated cardiac disease, and can be used if myocardial failure results from hypovolemic arrest while the team is providing fluid and appropriate transfusion resuscitation. Other drugs during pregnancy. With each condition, consider the effects of vasodilation, vasoconstriction, positive and negative inotropic and chronotropic effects of drugs. This table lists the potential fetal effects arising from cardiovascular drugs during pregnancy. ACE inhibitors may cause skull defects, oligohydramnios, and may adversely affect fetal and neonatal arterial pressure control and renal function. Warfarin is teratogenic in the first trimester. It increases the risk of fetal hemorrhage and increases the risk of miscarriage and stillbirth. Beta blockers may cause intrauterine growth restriction, neonatal hypoglycemia and bradycardia. There are no reports of toxicity of sildenafil in humans, but toxicity has been demonstrated in animal studies. Thiazides in the third trimester may cause neonatal thrombocytopenia. There are no reports of harm of digoxin to the fetus. There are no reports of serious harm in the third trimester for hydralazine. Manufacturer advises avoid use of hydralazine in first and second trimester. Low molecular weight heparin is not known to be harmful to fetus. Unfractionated heparin is also not known to be harmful to the fetus. Calcium channel blockers can cause uterine relaxation and thus may inhibit labor. Diltiazem should be avoided. Verapamil may reduce uterine blood flow. Regarding antiarrhythmics, most common arrhythmias in pregnancy includes premature atrial beats, premature ventricular beats, sinus tachycardia, and sinus arrhythmia. Rarely, arrhythmias may lead to hemodynamic compromise, requiring pharmacological or electric intervention. Many antiarrhythmics have teratogenic effects during first trimester. Amiodarone therapy during pregnancy may cause fetal or neonatal hypothyroidism and goiter. Thus, the use of amiodarone in pregnancy should be limited to maternal or fetal tachyarrhythmias, which are resistant to other drugs or are life-threatening. The following drugs are considered safe in the treatment of arrhythmias in pregnancy: metoprolol, propranolol, sotalol, verapamil, procainamide, flecainide, propafenone, digoxin, and IV adenosine. Regarding electric cardioversion, fetal monitoring is suggested before and after cardioversion, as there is a small risk of fetal arrhythmia. Magnesium sulfate can lead to hypotension. terbutaline can cause tachycardia and increase myocardial contractility. Recovery care. The first 24 to 48 hours after delivery is associated with significant hemodynamic changes and fluid shifts, which may precipitate heart failure and arrhythmias. Expect the period of highest risk to be 1 to 2 hours post-delivery when vasoactive uterotonics are given. There may be unpredictable blood loss and unpredictable volume of autotransfusion during this time, and cardiac output usually peaks during this time. Level of postpartum care should be individualized based on clinical status, monitoring and therapeutic needs, and ability to provide these resources. Include frequent assessment of breast for symmetry, redness, engorgement and pain, uterus for placement and tone, bladder for distension, bowel for sounds of intestinal motility, lochia, laceration or episiotomy wounds for signs of infection, lower extremities for signs of thrombophlebitis and thromboembolism, emotions or signs of postpartum mood disorders. Maternal cardiac arrest. This occurs in 8.5 per 100,000 deliveries. In the event of a maternal cardiac arrest, the anesthesiologist has multiple roles as code team leader and is a critical resource for performing code tasks. The code leader should not be task saturated and should be able to direct interventions, communicate effectively, and periodically reassess management goals and outcomes. CPR should be performed as usual, with similar compression to ventilation ratios, application of backboard, airway support, medications, dosages and defibrillation as necessary. Key differences in the pregnant patient includes preparations for fetal delivery parallel to the maternal resuscitative efforts, application of left lateral uterine displacement, avoidance of nasal airways, placement of IV access above the diaphragm, need for neonatology team for fetal resuscitation, surgical or obstetric team to perform perimortem caesarean delivery at the site of maternal cardiac arrest within 4 to 5 minutes, should there be no return of spontaneous circulation in which the uterus extends to or above the umbilicus. If available, early use of veno-arterial ECMO and transesophageal echocardiography in the setting of maternal cardiac arrest is encouraged. These are my references. Thank you.